So let's go ahead and get started with our day 2. We're very excited to present a panel of well-known physicians and some very important topics that we'd like to be able to talk about. I'd like to first introduce to you Dr. Elizabeth Bronlin. She's a PhD and a professor of pediatrics at the University of Minnesota Medical School, who practices at the University of Minnesota Masonic Children's Hospital in Minneapolis. And she's going to talk about what's new with the heart in MPS and ML. So let's welcome Dr. Bronlin.
Well, it's a real delight to be here, and I just wanted to share with you that I was here yesterday with the genetics masterclass for the young trainees that Dr. Munzer organized, and I don't think we have to worry. I think you'll be in great hands with all these bright young geneticists who are up and coming. So what's new with the heart in MPS and ML? I'm a conflicted individual, and these are my conflicts. And this is a data-based presentation, but the opinions and the interpretations are my own. So the objectives are to learn how MPS is affected by age, mutation, and treatment, to learn what part of the heart is involved with MPS and mucolipidosis, and to learn about current therapies for the heart. So the heart features of MPS are affected by several things. They're affected by the type of MPS you have, by the specific mutation, by your treatment status, and by your age. So if you look at the type of MPS, the heart is more involved if you have MPS 1, 2, and 6, and the coronary arteries are involved if you have MPS 1 and 2. Well, why is that? Well, one of the things that is not said often enough is that the compounds that accumulate in the MPS disorders are compounds that we all have. Dermatan sulfate, heparin sulfate, keratin sulfate, these are all naturally occurring compounds. They're not odd or different. They're the same compounds we have, and they're important compounds. For example, dermatan sulfate is heavily expressed in the heart valve, and it acts as a shock absorber for the heart valves. You know, the heart valves open and close and open and close 100,000 times a day and millions of times in a year. And if you didn't have dermatan sulfate acting like a cushion, it would be like folding a piece of paper over and over again. At some point, the valve would just rip if there wasn't dermatan sulfate in the valve. So these are compounds that are normally present, but in MPS 1, 2, and 6, dermatan sulfate accumulates in the valves. It's normally present there in everybody. And then the heart is less involved in MPS 3 and 4. That's not to say it's never involved in MPS 3 and 4, but less so. In addition to having the type of MPS, there are hundreds of mutations that have been identified for each of the MPS disorders. Back when we were first doing bone marrow transplants with MPS, we thought that there might be 1 or 2 different mutations, but it turns out there are some that are common and severe, and we've identified those, but many are family or private mutations involving only 1 or 2 individuals. There have only been a few that have been associated specifically with heart disease. There's a type of MPS 6 that's seen in patients who have come from Russia or Eastern Europe that have very little in the way of skeletal disease but have severe cardiac disease. But I would say right now that matching the genotype to what a patient has for clinical features is a work in progress, and we're just at the beginning of trying to identify mutations that have specific cardiac disease in them. So it makes prediction of what's going to happen pretty difficult. So then there are treatment status, and one of the things that some of you have done is undergone a bone marrow transplant, And bone marrow transplant's been around since 1980, but in 1980, the bone marrow transplant was a much different animal than it is today. For one thing, the patients that we saw in 1980 were a lot older. The first MPS 6 patient that was transplanted was 12 years old when she underwent bone marrow transplant. The conditioning regimen that we used for bone marrow transplant back in those days was a lot stronger. There was total body radiation that was very high dose. The donor matching was less robust. We used antibodies sometimes to match donors. We've got much more sophisticated donor matching right now. And the outcomes reflect all those issues from early transplant. So all the organ systems could be more involved by storage because the patient was older, and radiation effects on the patient play a significant role in the long-term outcome. From about 2000 on, the patients were much younger when they came to bone marrow transplant. The conditioning regimens were much more gentle. They used less radiation, sometimes no radiation. And we did things like monitor busulfan dosing, and donor matching improved, and we used cord blood. So those patients will look different than the ones that were transplanted back in 1980. Same thing historically happened with ERT. When ERT was approved, the patients generally were a lot older who had received ERT, generally more than 5 to 7 years of age. They had attenuated disease, but that didn't mean they had milder disease, and they had a long time to store the disease in their bodies. And so the results for ERT from patients who started enzyme replacement when they're older look different than those that start when they're younger. And now ERT is used in young babies before transplant, and it's often now used in newborns as soon as they undergo newborn screening for MPS 1. Storage diseases, no surprise here to anyone in the room, are progressive, and early recognition in treatment is very important. There's less storage and there's less organ dysfunction. I don't know if Lauren Clark showed you this slide yesterday, but I show it to all the families who I see. And this is, have you seen this picture before? Did Dr. Clark show it to you yesterday? This is an Italian family. They have attenuated MPS 1, and the little girl on the left of the picture started treatment at the age of 5 with enzyme replacement therapy. At the same time she was diagnosed, the family was pregnant with the little boy. He too had the very same mutation, and he started treatment at 5 months of age. You look at that little boy, he's 12 years old now. He's the same size as his 16-year-old sister, and he really has very little in the way of clinical findings of MPS 1, including in his heart. So that's the goal of early diagnosis and early treatment of the MPS disorders. So what parts of the heart are involved in MPS and mucolipidosis? Well, the valves, the coronary arteries, which supply the heart muscle itself. The heart muscle itself can be involved, and the aorta, the main blood vessel that leaves the heart and provides red blood to all the parts of the body. So valve disease is pretty common in MPS, and we're going to see if we can make this play. This is a two-dimensional cardiac echo that shows the left ventricle, and you can see that the left ventricle is contracting, and on the I can't really make this, I'm pretty sure I can't reach anything but the wall here. What you see is regurgitant flow, the blue sparkles going backwards on the upper right-hand part of the screen. That's mitral regurgitation that you can see easily on a two-dimensional echo. That's most common finding in the MPSs is mitral regurgitation. Successful valve replacements have been reported in many cases of MPS, and in at least one case, mitral valve replacement has occurred in mucolipidosis. Aortic valve disease occurs in MPS and mucolipidosis as well, and you can see on the left-hand side is a still frame showing the thick valve leaflets that look kind of like a Mercedes-Benz sign. Usually you don't see those valve leaflets nearly as well as you do with the MPSs and MLs. And here is a two-dimensional echo that shows blood going out the aortic valve to the upper left of that image and then falling back into the left ventricle. So that's a picture of aortic insufficiency. And we can not only see aortic insufficiency, but we can tell how much aortic insufficiency there is based on the cardiac ultrasound. Aortic insufficiency is well tolerated in people in general, and it is also noted for having successful valve replacements in both MPS and mucolipidosis. The next thing that is involved in the heart is coronary arteries. Coronary artery picture on the upper right-hand side is a coronary artery from a normal 3-month-old. You can see the white in the center of the picture is the lumen where the blood goes, and so that's a nice normal coronary artery. And on the bottom is a picture of a coronary artery from a baby who was only 10 months old who had MPS 1. And you can see that the white part is only a little slit. So that is what can occur early in MPS 1 and in MPS 2. Actually, coronary artery involvement has been reported in every type of MPS. It's just very rare in some patients. We found that it's unrelated to cholesterol, that the coronary arteries in patients who have MPS tend to be thick, but they're not associated with metabolic syndrome or hyperlipidemia. And the thing that makes it tough when you have coronary artery disease is that it's hard to find, because in contrast to adult coronary arteries where the disease is lumpy, bumpy through the coronary artery and you can see it pretty easily, this coronary artery disease is very diffuse, so you inject the coronary arteries even with an angiogram, and just that little increase in pressure dilates the whole coronary artery and it looks just fine, even though in reality it looks like that bottom picture you see there. We think that coronary artery disease is arrested by both bone marrow transplant and enzyme replacement therapy in MPS, but it depends on where you start. There are reports of very serious coronary artery disease in 20-year-old patients who start enzyme replacement therapy and then die suddenly a year later from severe coronary artery disease that wasn't expected and was probably there when they began enzyme replacement therapy. And in a couple of rare reports, there are severe coronary artery narrowing in babies, and it's a race to get them on enzyme and bone marrow transplant before the coronary artery totally closes up altogether. So decreased heart function can occur in both MPS and mucolipidosis. And on the left-hand side, it's pretty common in MPS 1 and MPS 6 babies to have some decreased function. And so this is a picture of the left ventricle and the right ventricle squeezing, and you can see that the heart rate's kind of fast and the ventricle doesn't squeeze in a really consistent and organized fashion. This is somebody who showed up at about a month of age, and if you calculated their squeezing fraction, it'd be about 30%. Lower limit of normal is 50%. So that baby got enzyme replacement therapy, and within 2 months, the function improved to normal, and so the baby was able to get a bone marrow transplant. I mention this to you because some physicians say, oh, the baby is too sick for enzyme replacement therapy. Well, what the baby really needs is enzyme replacement therapy, and you should say, no, that's not right. Just let's move ahead with ERT. Okay. So it's interesting, heart transplant has actually been reported in MPS 2 and in a lady with MPS 3 with very mild neurological symptoms, and in mucolipidosis type 3. That's if the heart function deteriorates despite treatment or if there is no treatment. And it's very interesting that one of the things that you look for in the heart muscle is you look for storage of the compounds, and you look for scarring from the storage. And in mucolipidosis, the test that they did was a cardiac MRI, and they actually did see scarring in the heart muscle itself in the lady who underwent heart transplantation. So the other part of having deposition of storage material in your myocardium is it can go to the conduction system. And this is an EKG, and you can see that there's a spike in the middle of the two little hills, and it goes along quite nicely until there's no more spike. Well, that means that the electrical signal is not getting from the upper chamber to the lower chamber, and there's no heartbeat. So that catches the attention of the anesthesiologist right away when the heart stops in the middle of a case. So one of the things that we need to do is follow an EKG, and we can actually measure the time that it takes the electricity to go from the upper chamber to the lower chamber, and we can track it and know if we need to do anything like put a pacemaker in. So this kind of problem has been reported in MPS 2 and MPS 3 and MPS 6, and sometimes happens when you have anesthesia for the strangest things like a dental procedure. So it's a good idea to know that your conduction system is okay, and for sure if you have symptoms of dizziness or fainting, you need to let your cardiologist know, and they'll do a further investigation. So the final thing that has been reported is aortic root dilation. You see on the left-hand side a tube going off to the right-hand part of the screen. That's the aorta. And then the arrow is pointing to the aorta in a patient with MPS. Tends to get dilated and get bigger than it should. So far, nobody's needed to have their aortic root replaced. It seems like it just gets so big and then just stays put. Doesn't seem to matter whether you've had ERT or a BMT or are untreated. It just seems to be a little bit big, and it's been reported in all MPSs. So what do you need to know for heart care? Well, it's important that you find a team, and you're going to have to educate your cardiologist because not many cardiologists see patients with MPS. It would be great if everybody lived in Minnesota or in Duke, near Duke, or in California by Paul Harmatz, but I guess that isn't very realistic. So it would be good to find one that understands the problems, is willing to be up to date in knowledge, and he knows who to ask for advice. And most importantly, your cardiologist just doesn't see you and go on to the next patient, but remembers what he sees or she sees and works to advance knowledge in the field so that things get better and better for people with MPS. So there's a couple of types of cardiologists. There's a pediatric cardiologist, and that's what I am, so I take care of kids mostly. There's an adult cardiologist, and they take care of patients with coronary artery disease. But within those two specialties, there's more subspecialty than that. There's a new field called adult congenital, and those folks can be either pediatric cardiologist or adult cardiologist, and then they take an extra 2 years to learn about adults who have congenital heart disease or rare diseases. So that's an option going forward for young adults and adults in general with rare diseases. And then there's an electrophysiologist or an EP doctor who specializes in the conduction system of the heart. So whoever you find, it would be nice to have the same person and to have that person really be interested and willing to learn in the field. So when do you need a cardiac evaluation? Well, for sure you need to know where you are when you're diagnosed with MPS or mucolipidosis. And you need it regular follow-up exams. If you have very mild disease, you might only need to see a cardiologist every 2 to 3 years, but if you have valve disease, you're probably going to see somebody annually to follow up on what the leaking of the valves is looking like and whether or not there's any narrowing of the valves, which can occur late after several years of having regurgitation. And then certainly if you have any new questions or concerns, you're short of breath, you can't finish a sentence without taking a breath, you have dizziness like I mentioned before, things that are just not right. And finally, you should have an evaluation if you're going to have a big orthopedic surgery or if you're going to have a neurosurgical procedure. And this is what you should ask for. You should ask to make sure that you have a blood pressure taken, that they listen to you. Now, they might not hear murmurs because you have to have a pretty robust type of mitral regurgitation before the murmur's heard. You want somebody to do a two-dimensional echo on you. And a lot of places with little kids have to sedate little kids because they don't feel comfortable echoing little kids without sedation. We're blessed in Minnesota to have a tech who's done echoes on kids for 30 years, and so I've come into the room and seen him echoing with the transducer in his arm and the baby hanging off of his arm. And I say to him, "What are you doing?" And he says, "I'm doing my thing and they're doing theirs." And so, depending on how the tech, you really oftentimes don't need to have sedation. Now, the tech may have to sit on the floor and the child may sit in the mother's lap, and it's going to take some, innovation, but you don't necessarily have to have sedation for the echo. You should get a cardiac an EKG to make sure the conduction system's okay. And periodically you should have a 28 or 48 hour EKG. Standard EKG has about 30 heartbeats on it. 24-hour EKG, you'll have 100,000 heartbeats, so you'll be able to have a much better view of what's going on when you're asleep, when you're exercising, and throughout your day. Then the other lab work that we usually get in Minnesota is a troponin, which is a compound that's held within the heart muscle cells itself. So if the heart muscle cell is damaged, the troponin will leak out, and we can determine that with blood work. And an NT-proBNP is a blood test to tell you what kind of stress your heart is under. And finally, we get a lipid profile just to make sure you don't have any high cholesterol or anything like that, and that's based primarily on family history. So what I found recently in the clinical trials is that BMT is offered for MPS 1, 2, 4, and 6. It's not recommended by most people in 2, 4, and 6. We do primarily 1, but there are centers that are doing those bone marrow transplants. There are gene therapy trials in 1, 2, 3, and 6, and there's a clinical trial for biomarkers in mucolipidosis. And so the map you see below has got the number of clinical trials going on based on the state, and no surprise, California, Minnesota, Pennsylvania, and North Carolina have the most activity in the clinical trials. So valves, coronaries, heart muscle, aorta, all involved in MPS, and most have been reported in mucolipidosis. Non-invasive approaches to valve replacement may be possible in some adults with MPS and mucolipidosis. They've been reported that you can put an aortic valve in the cath lab by threading it through an artery in your leg. Progressive storage makes earlier detection important. And when you think about how far we've come with MPS 1 and remembering what that sibling pair looks like, shouldn't we be lobbying for newborn screening for every MPS and mucolipidosis? Even though we might not have a treatment right this moment for all of them, don't they deserve to be found early, just like MPS 1? Thank you.